HIT 352, Health Information Systems. And we are now on week 9 talking about the EHR, or Electronic Health Records. If you look in your syllabus, we are still on course objectives 8.2.3.4, which correlates to learning objectives 9.2.1 through 9.2.7, 9.3.1 through 9.3.3, and 9.4.1 through 9.4.7. And we will stay on those, it looks like, until at least week 13. So, if you have questions about that, take a look at that. But these are the learning objectives from the book for Chapter 9. So let's talk about those. We want to talk about plans for an EHR, look at clinical vocabularies, support the need for and address issues related to the EHR, educate providers on the benefits of EHRs, look at what are the multiple information systems that are required to support the EHR, what about the PHR, which is the personal health record, and so we have lots to cover. EHR, an electronic health record on an individual, conforms to nationally recognized interoperability standards. Okay, let's stop and unpack that for a minute. An EHR has to conform to nationally recognized interoperability standards. Make sure that you know that about the EHR. Make sure that that's very clear in your mind. Authorized clinicians and staff across more than one healthcare organization can create, manage, and consult. I'm not sure if you have read To Err Is Human yet. It was produced by the Institute of Medicine, which is now known as the National Academy of Medicine. If you have not read To Err Is Human, please stop and take time to do that. I am trying to get that built into some first year courses so that hopefully by the time students get to their second year, they're like, oh yeah, I already know what that is, and I've read it and all of that. But what the report did is it advocated for use of health information technology to help prevent mistakes that regularly occur in the delivery of healthcare and lead to injuries and deaths of tens of thousands of patients. When you are talking about health information technology, we're talking about hardware, software, integrated technologies, related licenses, and intellectual property. There are upgrades and packaged solutions, and EHRs, or health information technology, is designed for or support the use of healthcare facilities or patients for electronic creation, maintenance, access, or exchange of health information. So that's really what it's all about. The EHR really is trying to build a longitudinal health record. Make sure that you know that word, longitudinal. When it comes to an EHR, that is the goal, that you have a longitudinal health record, meaning it goes the gamut. It goes from birth to death. It is longitudinal. It follows the patient. It is a permanent record. It is maintained, the information is in chronological order. It's, as I mentioned earlier, it's across time. It's not necessarily limited to the healthcare facility, but is accessible remotely for providers and the consumer. So keep in mind, we're still talking about the EHR, the electronic health record, and this is what we're trying to do with all the components that make up an electronic health record, is create that longitudinal health record that is permanent, in chronological order, maintained ideally from birth to death, and that is accessible remotely. So make sure you know that. It is the electronic collection of all patients' health information and clinical care. It's stored, managed, and referred to by authorized members of a single healthcare facility, and it is much like actual paper health records, but only in digital or electronic form. What does interoperability mean? It's the ability of different information technology systems and software applications to communicate. That's what interoperability is. You want them to be able to exchange data accurately, effectively, and consistently, and I would add timely. And make sure that the information can be used that has been exchanged. So whatever's been exchanged, you want to be able to use. It includes reimbursement, diagnostic and procedural coding, claims processing, computerized provider order entry or physician order entry, you may have known it as, CPOE, results reporting for lab, radiology, pathology, those types of things. E-prescriptions can be sent to the patient's pharmacy. Medications are managed. Population health reporting is possible. Quality improvement activities can take place. Clinical decision support is available. Healthcare facility administrative reports and analytics are done, and other additional authorized activities. That's all part of what the EHR is about. In your book, and I'm trying to really quick look up the page. Where is it here? Which page was it? Okay, page 152. If you look at your textbook for page 152, at the bottom of that page is figure 9.4, a conceptual model of an EHR. I love this. I love this visual because it shows you what is a source system, what is in the core clinical systems, what's supporting infrastructure, and what's connectivity systems. And under source systems, there's administrative and financial applications, departmental clinical applications, specialty clinical systems, and smart peripherals. That's all made up. Those four things right there, administrative and financial, department clinical, specialty clinical, and smart peripherals, those all make up what are the source systems for an EHR. And an EHR has source systems, core clinical EHR systems, supporting infrastructure, and connectivity systems. And that is such a great visual to see how an EHR is made up. It's made up of all these components. So I'm going to refer you there as we go through these slides, and I'm going to kind of skip through because so many of them are covered in your book when you look at starting on page 152 where it says components of EHR. Yes, there is a core data set. There's relevant administrative, demographic, clinical information about patient health care. ASTM International has developed standards. They are the standards development organization, and they have come up with a core data set that defines the minimum requirements for a continuity of care record. And let me jump back here. Okay, the continuity of care record is a core data set, and it has all of these items in it. And it also has these standards. And the data can be presented to care providers in electronic format or in paper format. And obviously we're talking about the EHR, so it's going to be electronic format. So everything in the CCR has to use either XML or HL7. So make sure that you're aware of those. All right, HL7, this talks about what that is and how that was developed, so please be familiar with that. Moving on to a PHR, it can be electronic or paper. Typically it's electronic. It allows the patient themselves to maintain it and update it. Patients sometimes want their own personal information added to their record, and a PHR is where that can happen. Now, the PHR is not the legal health record. It's different than that. And make sure that you understand that. And if you need to, go back to your book and take a look at that. It's used to collect, track, and share past and current information about health or the health of someone in their care. All right, status of EHR adoption. I'm going to apologize right here. It seems like this slide set is very choppy. It doesn't follow very well, and I apologize for that. But we'll just kind of I guess we're leapfrogging from one topic to another, and hopefully we can stay together on that. EHR adoption, there is a federal agency called ONC. It's the Office of National Coordinator for HIT, and they are trying to get every healthcare organization provider to adopt electronic health records. And they establish guidelines and requirements for that. They advise the Secretary of the Department of Health and Human Services. So you need to know what ONC is and what they do. And you need to know why they're doing what they're doing. They ultimately want to use health information technology to improve healthcare in the U.S. One of the other things they're trying to do is implement a nationwide health information exchange, meaning that patient information from all of these regional health information exchanges and large health systems are all pooled together so that it's available. If a patient, let's say from Iowa, goes down to Florida on vacation and has some kind of an accident or an illness and they go to the hospital, that through the EHR adoption and through a nationwide health information exchange, their information, their past medical history and that type of thing, past list of surgeries and whatnot, is available to that emergency department provider in a Florida hospital, even if the patient lives and gets all of their other health care in Iowa. So that's really what that's about. Meaningful use. Now I'm going to stop here really quick because I need to tell you meaningful use is essentially meaningless. Meaningful use is almost over. It started, I believe, in 2014 or 2015, and it ends in 2021. The last payment cannot be made after 2021, and most state programs for meaningful use end in 2021 or have already ended. And meaningful use as a topic, so to speak, has essentially been morphed into MACRA, at least on the physician side of life. There are some meaningful use pieces of information that are provided by hospitals, but again, most all of this is played out. So this is, you learn this, but it's essentially a piece of past history in most cases. But the Meaningful Use program was developed for monetary incentives to spur the acceptance and adoption of health information technology and EHRs. They used what was called certified EHR technology, and make sure you know these letters, CEHRT. You need to know that certified EHR technology is CEHRT, and it was used to do these things. You had to be able to prove that your system did these things in order to get the monetary incentives. And it also included quality of care indicators like HEDIS measures and other things, and core measures as well for quality of care. And then you had reporting requirements. Many healthcare providers were not eligible for the payments and they didn't want to get involved. They didn't want to have to do the work. But many did the work, got the money, and then the government standards changed or the monetary incentives ended, because I think that it was a 5-year program. So if you started in 2014, you were done in 2019. If you started in 2015, you were done in 2020. The latest you could start was 2016, and you'd be finished in 2021. And it varied from state to state, although there was this federal component. Some obstacles, again, were interoperability issues. Some of those were related to the IT vendors that were used. Others had to do with the equipment, or they had to do with what the organization was willing to do in terms of creating interfaces, or finding that that was too expensive, so they didn't do it. There were a lack of standards for EHR systems and implementation. A lot of it was vague, it lacked specificity. So these were all obstacles to EHR meaningful use type situations. Best practices still have yet to be refined, publicized, and consistently implemented. And then there's also the topic of health information blocking. This remains a bit of a challenge as well. Health information blocking is when a person or an entity like a vendor knowingly or unreasonably interferes with the exchange or use of electronic health information. So for instance, you could have a vendor who sets it up that how their system is built blocks information sharing such as interoperability so that the system will not be a part of an HIE, the Health Information Exchange. So you have those kinds of situations. That's health information blocking. So just make sure you know what that is. And in order to be CEHRT, in order for your system to have that certification, it had to be authorized by the ONC. So for instance, I've worked with Cerner and with Epic Systems. They both have, each version of their system has to have this certification, the CEHRT. And they get a number that is from the federal government that says, yes, this has been evaluated by ONC and authorized and it's appropriate. And it meets the criteria set by the Meaningful Use Incentive Program. If you don't have that CEHRT number validating that it has been authorized and certified and meets the criteria, you will not be eligible for a meaningful use incentive. And this just goes into that further, and you can read about that. And you can read more about that. I'm going to refer you to your book, or if you want to take a look on the internet, I'm sure there's quite a bit out there about this. And then this gets into the components of an EHR. And again, remember I referred you to page 152 in your book, so you can read through a lot about all of these. Hopefully you are familiar with what these each are and what they mean and how they're utilized. So what are some benefits of EHRs? Well, it's definitely easier access to clinical information, and you do get current information as long as it's being captured and put in the system. It does no one any good if you have someone taking vital signs and they write it down on a piece of paper and it takes them 2, 3, 4, 6, 8 hours to get back to a computer and put it into the computer. That's not current. And that's where process can sometimes defeat a benefit of the EHR. It does have reminders and alerts, but again, one trouble is if you have somebody who always bypasses the alert. Oh, I see an alert, I'm going to click through it instead of reading it and assessing it. There is such a thing as alert fatigue, that caregivers who are documenting in an EHR get so many alerts so many times a day that they just end up clicking through them because of alert fatigue. And how do you get around that? How do you make sure that the alerts that they need to know and they need to look at are addressed and not just clicked by and ignored? EHR can enhance documentation captured. It can also not enhance documentation captured. It depends on how your system's set up, what it actually does capture, and what fields do you make mandatory that they can't move any further in their documentation until they fill it in or they select something. So it's really, it has the potential to enhance documentation captured, but in real world, real life situations, it depends very much on how your system is set up. Theoretically, and I'm putting that in front of this last one, theoretically, it allows healthcare providers to spend more time with patients. However, there have been many studies and many anecdotal stories where this is not the case. A really good system will allow providers to spend more time with patients. A really bad system means that providers are staying late at the office or staying after their shift at the hospital for 1, 2, 3 hours to finish their documentation. So these benefits are there, yes, but in reality, they may not be if the system is not set up and monitored and you don't get provider input into screens and clicking and capture. Test results can be available immediately upon completion. as long as your interfaces are up. If you have a lab system that's interfaced to your main system in your EHR and that interface goes down, your lab results are not immediately available. So, but if that interface is up and functional and it's been thoroughly tested and it's accurate, yes, it does that. And then theoretically, it supports various data analytics functions. It can do that, but again, it's how is it set up, how is it built, how is it tested, how is it functioning, how have people been trained to use it? Because that's the other thing. You can have the best EHR in the world, but if you don't train people to understand how it works and how the bells and whistles work and what's available, you're losing so much. And here are economic and administrative benefits, and I'm going to again skim through this. And again, I'm going to put the word theoretically in front of most of this. Barriers to EHRs. Cost is probably the biggest barrier. I challenge you to go out and Google what the cost of these systems are. It's outrageous. If you haven't already looked at the cost, it's just outrageous. And then there are times where you have limited access to the HR vendor, their information, and their technical assistance, which is incredibly frustrating. And then the suitability of EHR products for practice and rural healthcare settings. And I would also add in there sometimes some of the areas like long-term care. When they build EHRs, typically they're building them for a hospital setting. And they don't, and what works for a hospital does not work for a practice and certainly doesn't work in a rural healthcare setting. So sometimes EHRs, how they're built, is challenging and a barrier. And then difficulty connecting to or obtaining broadband service. With all the internet issues people have had, especially after the derecho storms, broadband is critical, and when that's down, you're back to paper. Signatures. One good thing about the EHR is it allows you to capture signatures electronically, or the identity, I should say, the identity of individuals who are doing entries. But again, if you sign into your computer and you do your documentation and you don't sign back out, and somebody else comes and sits in your chair, pulls up the screen, they can start documenting underneath your identity. So signing out when you're done is so critical. But that identity, if it's done correctly, that identity of that person can very well be kept. And there are systems that use biometrics to capture that, whether that's a fingerprint or the veins on the palm of your hand or a retinal scan. There are all those kinds of ways that systems can validate that it really is you. Authentication means that the person is who they claim to be. So if I sign a document electronically, I'm authenticating it. I'm saying that I am me and I'm signing off on this document. And that's different than a digitized signature, which takes a scanned image of my actual signature and sets it in there. Electronic signature usually has a password but can use a two-factor authentication method, and digital signature often has encryption and whatnot. Copying and pasting, if you have not been exposed to that yet in your HIT education, let's just all say the word bad. Copying and pasting is bad. It saves time, but it can create an enormous amount of problems. It is taking information from an existing record or document and putting it into the current one that is being built. So for instance, a lot of times consultants are tempted to go copy paste the patient's past medical history, family history, and social history out of the H&P and put it in their consultation report. And that's fine as long as that information is current and accurate. But if the doctor that created the H&P that the consultant is copying and pasting from himself or herself copied and pasted it from another document from a prior admission 6 months or 12 months before, that's not going to be accurate. And then you've got copying and pasting once and copying and pasting again. It takes inaccurate information and moves it forward. So providers, people who document, like copy paste because it saves them time, makes it easy. It can also make you end up with a 5 or 6 page H&P instead of a 2 to 3 page H&P. But again, you have to just really educate on this and awareness and auditing. So again, this goes into what's happening with copy paste. It can essentially raise questions about the accuracy of the entire record. If you get into litigation, like a medical malpractice case, and I have seen this done, where they take the information and they blow it up on the screen, a very large screen, and they put it in front of the judge and jury, and they basically say, and they show the documentation, and they point out, the lawyers point out all of the inaccuracies. And then, meanwhile, you've got the provider or the physician saying, but no, I mean, yes, that's inaccurate, but this is accurate. And it just, yeah. So you can see the trouble there. It can also be an issue with fraud. It can also cause fraud. And it can result in harm to the patient because if you copy and paste inaccurate information, that could result in a treatment decision for the patient that could cause harm. And it might end up being a sentinel event that has to be reported. Audit logs or audit trails, those are very important. You need to know what happened and who did it. Anytime there is any kind of access to a record, you see this a lot of times with celebrities and HIPAA breaches, that somebody who's well known, and I'm going to use George Floyd as an example. He was brought into the hospital in Minneapolis, and the hospital in Minneapolis did an audit, and they found all of these individuals. There were quite a few, I want to say 10, maybe more than 10, who had accessed his record inappropriately. They did not have a work-related need to access his record, and they had to be punished for that. And I think some of them were even let go. But, and I'll leave you to look up all the details on that. But the point is that you have to be able to audit what is happening with the record, what is happening with the data, what is happening with the information, who is accessing it, and why, and when, and where, and be able to know that you're protecting it, and that if it's being modified or if you're talking versions, that's all being captured. What's being changed between versions? What is the most current version? And so this talks again about maps and all of that. Printing is another one that's really critical to watch. Who is printing what? When did they print it? Where did they print it? Exactly what did they print? These are some other EHR tools. So be sure you're familiar with all of these. Graphical user interface is called a GUI, G-U-I, GUI, just so you know that. And here are some more. NLP, natural language processing, that's another one be sure you know. So legal issues, obviously state laws vary. Each state has their own laws. So what is acceptable in court and it's all based on your state laws. So you've got to know your state laws. Documentation has to be in a usable and readable format. It has to be formatted, and you can't just have screen prints. Subpoenas may require a healthcare organization to produce audit trails, decision support rules, clinical guidelines, all those types of things. So once they're used, they have to stay in there permanently. Even if you have a clinical guideline that was in place for 3 months, 2 years ago, you still have to keep that and be able to show when it was in use and what it was, what were the contents. So as you can see, retention, storage, security, privacy, signatures, data quality, those are all legal issues. And then again, these are some unanticipated issues in EHR work or EHR use that have come to the surface since EHRs have increased in their use across the nation. These are some things that people weren't necessarily expecting, but that they have found to be consistently true. And some more. This goes back to interoperability, talking about the difference between basic, functional, semantic. Make sure you are familiar with all of these terms and what they mean. I think I've mentioned this before. A hybrid record is a combination of paper and electronic health records. And typically in a hybrid record situation, you usually have some scanning going on, taking that paper and turning it into electronic record. But you may also choose to have certain things that remain in paper and they're stored separately from the electronic record. And those are very hard to manage. Been there, done that. Because you've got to remember what's where. Impact on HIM. Oh goodness, every HIM function is impacted by an EHR. And whether that you're going from paper to a hybrid to an electronic system, or if you're just even changing up your EHR systems, all of these things are impacted. And when you're doing this process and you're moving from paper records to a hybrid record or from a hybrid record to an EHR, or if you, heaven help you, you're going straight from a paper record into an EHR, yes, you still have things that don't cease to exist that have to be transitioned, and you have to think about how this is going to work and how is this process going to happen. And it's not just taking paper processes and making them electronic. That's one of the worst things you can do. You need to make the technology work for you, and so your new processes need to be based on what the technology does. And that is it for chapter 9. Sorry, chapter 9 for week 9. All right, take care. Have a great week. We'll be back next week to talk about consumer informatics. Bye for now.